Good morning everyone. I am Dr. M. Subhashini from the Department of Conservative Dentistry and Endodontics. I am working as an assistant professor in Vinayaka Mission Sankaracharya Dental College. I am here to talk on the topic of regenerative endodontics. To begin with, regenerative endodontics is nothing but a recent advancement in the field of dentistry. Endodontics has come a long way since 1687 when Charles Allen authored the book for dentistry. Since then, there has been a remarkable development in dentistry, especially in endodontics. Utilizing the reparative capacity of the dentino-pulpal complex for the treatment of pulpal and periapical pathologies has become the holy grail of endodontics. This is made possible because of rapid development in the field of reparative medicine and tissue engineering. Conventionally, the treatment of immature necrotic pulpal tissue for the open apex were used to be the apexification procedure done with the help of calcium hydroxide, or the apical barrier techniques, which involves the placement of MTA in the apical end. But then the disadvantages of both the techniques were incomplete development of root and the dentinal walls were thin and fragile. So it was not able to resist the forces exhibited by the mastication. Hence, these techniques were not followed after then. Regenerative endodontics. It's a most recent techniques to treat the immature permanent tooth with open apex which has got a necrotic pulp. The speciality of performing the regenerative endodontic procedure is that it helps in achieving the root canal length as well as the dentinal wall thickness. Hence, the tooth was better able to resist the forces and it can reverse the tooth in its natural and original contour. Regenerative endodontic procedure can be defined as a biological based procedure designed to physiologically replace the damaged tooth structures, that is the root structures including the dentin as well as the pulp dentinal complex. This definition is according to the American Association of Endodontics given in the year 2012. Hence, the aim of the treatment is to achieve the damaged pulpal tissue. We are restoring the damaged pulpal tissue using a biocompatible and a regenerative material to its natural and undamaged state. What are the contraindications of doing the regenerative endodontic procedure? It cannot be done in case of young deciduous tooth. It cannot be done in case of a periodontally weak tooth. Advantages of this technique, as I said before, it induces further root development in case of incomplete root development or immature or the tooth with open apex. It causes reinforcement of the dentinal walls by the deposition of these hard tissues, and it also strengthens the root against the fracture. Coming to the history of regenerative endodontics, it was in the year 1961, Nigel Osby was the first to identify the potential of repair if bleeding is induced in the root canal. In 2001, Iowa et al. Reported a case of revascularization. What is this regenerative endodontics and how is it performed? What are the requisites of the regenerative endodontic procedure? Stem cell, scaffold and growth factor. All these three forms a triad of the regenerative endodontic treatment. Without these, the treatment can't be performed. What is a stem cell? It is nothing but an undifferentiated cells which have the capability of differentiating into the cell of same type or different types. There are different types of stem cells available in the oral cavity. Stem cells of the apical papilla, dental pulp stem cells, periodontal ligament stem cells of the deciduous tooth. All these are the types of the stem cells in the oral cavity. Out of all these stem cells, the stem cells of apical papilla have shown a greater improvement and survival rate when a regenerative endodontic procedure is performed. It is able to differentiate much better and it has got a higher survival rate for the treatment success. Growth factor. These are the polypeptides which have the capability to bind to the specific receptors on the target cells. The functions of the growth factors are repair and regeneration. Scaffold. It is a structural element that holds the tissues or the cells together. It comprises of extracellular matrix proteins, namely proteoglycans and aminosoglycans. The functions of extracellular matrix proteins are tissue regeneration, cell anchorage, sequestration of growth factor, and proliferation. Regenerative endodontic procedure can be performed by different means. These are the types of the regenerative endodontic treatment, and the modes they performed are, it could be done by using the postnatal stem cells, that is the stem cells that is extracted from the skin or the bone. The skin or the bone acts as a source for the stem cells production. The stem cells that are isolated from these are injected into the canal. But then the disadvantages of this technique is that it is a difficult technique and it has resulted in a low survival rate. Next is the pulp implantation. The stem cells are grown in the laboratory as layers, and these are rolled into a 3D structure and implanted into the pulp space. The disadvantage of this technique is that the cell layers are found out to be fragile. Hence, this technique was not followed. Then comes the scaffold implantation. The scaffold implantation is nothing but the stem cells are seeded into the porous scaffold to facilitate proliferation and differentiation. Scaffold can be of natural and synthetic types. The natural scaffold is, they are many in number. They are blood clot, platelet-rich plasma, platelet-rich fibrin, collagen. The synthetic scaffold are polylactic acid, polyglycolic acid, polycaprolactone, synthetic hydroxyapatite, injectable hydrogels, that is polyethylene glycol. 3D cell printing. The 3D cell printing is nothing but a 3D printer is used to mimic the cell size and shape of the pulpal tissue of a particular tooth. The advantage of using this technique is that we can have a precise placement of the cells inside the canal. Gene therapy. Transfer of specific mineralizing genes is carried out into the canal with the help of a carrier. But the disadvantage of this technique is that it resulted in the formation of tumors. Hence, this technique is not used. Injectable scaffold. It is made of a material which is then directly injected into the canal. For example, polymer hydrogel. Of all these techniques, 3D cell printing is a recently evolving technique and has a high survival rate. Coming to the regenerative endodontic procedure, this procedure mainly involves applications of the triple antibiotic paste for the canal disinfection. In 1996, Hoshino and Sato recommended the use of the triple antibiotic paste, which comprises of ciprofloxacin, metronidazole and minocycline to disinfect the canal. Ideally, the concentration of the combination of these three drugs should not be above 1 microgram per ml. The procedure of regenerative endodontic treatment protocol was first suggested by Morton Troop in the year 2007, and this was approved by American Association of Endodontics as a standardized treatment protocol in the year 2014. The procedure is done as follows. In the first appointment, diagnosis should be done properly. That is, the permanent, immature, necrotic pulpal tissue with open apex is chosen for the treatment. Risk and potential benefits should be explained to the patient duly, and then the procedure is carried out. The tooth is anesthetized and it is isolated with the help of a rubber dam for access opening procedure. As soon as the access opening is done, gentle irrigation with low concentrated 20 ml of sodium hypochlorite for 5 minutes is done to minimize the possibility of extrusion of irrigant to the periapical tissues, followed by 17% EDTA irrigation. Only the low concentrated sodium hypochlorite is used as an irrigant, since it may affect the viability of the apical cells, or it may be cytotoxic in nature. A copious irrigation of sodium hypochlorite of low volume, low concentration is used. Canal is then dried with paper points and triple antibiotic paste is applied into the canal space. After the paste is applied, temporary filling is done and the patient is recalled after 3 weeks for a checkup. In the second appointment, patient is first evaluated for any signs and symptoms. If any signs present, the triple antibiotic paste is again applied and sent for review. If no signs or symptoms occurs, then we can proceed with the regenerative endodontic procedure. Disinfective agent is washed off by irrigating with normal saline and local anesthesia without vasoconstrictor is administered. Yellow without vasoconstrictor is given not to disturb intracanal bleeding. Final irrigation is done with 17% EDTA and dried with paper points. After drying, file is placed 2 mm beyond the apical foramen and bleeding is induced into the canal deliberately by over-instrumentation. Pressure is applied at the orifice for the clot formation. To position MTA about 3 mm, cola plug is placed in the canal orifice to serve as a matrix. Patient is then called for review at 3, 6, 12 and 24 months for both clinical and radiographic evaluation. So this picture depicts the periapical area with an immature open apex. In the second figure, a file is introduced intentionally 2 mm beyond the apex and a bleeding is induced. The bleeding, as soon as the bleeding is induced, blood flows through the canal and a clot is formed. MTA dressing is placed above the bleeding, followed by the coronal restoration. At the review of the patient is done at 3, 6 and 12 months interval. As a result, the root formation occurs and the dentinal wall thickness is achieved. What are the factors affecting the regenerative endodontic procedure? Improper disinfection of the canal, apex diameter. The apex diameter is very less. We cannot do the regenerative endodontic procedure. Deciduous teeth is contraindication for regenerative endodontic procedure. Molars are found to be contraindicated due to limited access and difficulty in the MTA removal. These are the measures given by the American Association of Endodontics to measure the success rate of the regenerative endodontic procedure and to measure the success rate of the tooth. The primary goal that should be found in the success of the treatment is elimination of symptoms and the evidence of the bony healing. Secondary goal is increased wall thickness and root length. And finally, we should also be able to achieve positivity in vitality testing. What is the difference between performing a regenerative endodontic procedure and why not apexification is no more followed? First and the foremost thing is apical closure is achieved and so the pulp vitality is maintained, whereas in apexification the apical closure is achieved only by means of the material, that is a calcium hydroxide, and the pulp vitality is not maintained. In regenerative endodontic procedure, the root length increases and so the root achieves its original contour, whereas in apexification procedure, the root length doesn't change. We intentionally close the root apex with the help of the material. In regenerative endodontic procedure, root width increases, whereas in apexification, there is no change in the root width. And so, the root width, no increase in the root width is not able to resist the forces exhibited, and so there will be a frequent fractures reported in case of apexification procedure. In case of regenerative endodontic, there is least possibility of root fracture, whereas in apexification procedure, more possibility of root fracture is seen. Coming to the conclusion, regenerative endodontic procedures have proven to be an invaluable tool for teeth with an open apex and necrotic pulp in young patient. These procedures have proven to produce a favorable biological outcome when compared to conventional apexification techniques. The procedures are expected to undergo major changes in the near future. Research needs to be done in many areas to make regenerative procedures more predictable. Thank you for watching my class.